Obliques of individual fingers should look the same as PA and AP in as much as contrast and density goes. Sometimes the obliques are beneficial in showing what doesn't show up between the AP and the lateral, or the PA and the lateral. So rotation is 45 degrees. And rotation in which direction depends on the digit. Again, a reference all the way back to the first semester. If we're looking at digits number 2 and 3, which would be your index finger, your middle finger, then you rotate towards the thumb, or which is really towards the lateral side. If we're looking at digits number 4 and 5, then you're going to rotate towards medial side, or the small finger. The reason for that is to maintain as low an OID as possible. Make sure your fingers are separated so you don't have soft tissue or bony overlap, and make sure that you keep them parallel with the image receptor. That does increase OID a little bit to keep especially digits number 2, 3, and 4 parallel to the image receptor, but again, what you're trying to maintain there is a parallel relationship with the anatomy in the image receptor, and a perpendicular relationship between the joint space and the image receptor, so that your central ray and your joint space are parallel to each other. So you do get an increase in OID, but it's acceptable, it's not excessive, and it gives you a much better image. I know in some hospitals it's acceptable and even protocol to use the fingers as props, to make the OK sign and then straighten each finger out individually, and use those fingers as props. And if that's hospital protocol, that's fine. It doesn't make for as good an image as if you keep the fingers parallel to the image receptor. But if that's what your hospital calls for and what your radiologist call for, then that's what you give them. In my personal experience, most radiologists, they're okay with the fingers being props, but they certainly are not going to balk if you keep your fingers parallel to the image receptor and give them open joint spaces. So 45 degree oblique. And I'm getting a little bit of ahead here, but what you get with a 45 degree oblique, what you should see, is the evaluation that we talked about in the PA of the fingers. We're going to use that. What we should see is on the posterior surface, the anatomy should be slightly convex, probably not convex, but pretty flat. And then we get an increase in concavity on the anterior side. And instead of having that symmetry of the soft tissue between the anterior and the posterior side, then what we should see is about double the soft tissue on the anterior side as opposed to the posterior side. Make sure that you increase your field size to include about a ½ inch past the soft tissue, central ray to the middle interphalangeal joint, and this one's nice and open. And that should give you the distal portion of the metacarpal. You shouldn't have soft tissue overlap. Unfortunately, we've got that over here. I'm not real sure why some of the images make it into textbooks, but they should have separated their fingers a little bit better than what they did here. So these are supposed to be comparison views, poor positioning, not comparison views, but poor positioning. This one's obviously a PA. You don't have that difference in soft tissue, and this one is truly a lateral. It looks really like a lateral, almost perfect lateral, really. So our evaluation for a lateral is really an exaggeration of the oblique. We have significant soft tissue on the anterior side, posterior side almost no soft tissue. And now we've truly got a convex appearance on the posterior side and a very steep concave appearance on the anterior side. So we're going to look at the fingernail. We've talked about that, but we're going to look at the soft tissue. look at the difference in convexity and concavity, and that's really how we're going to evaluate our obliquity. Twice as much soft tissue on the anterior side as what we have on the posterior side, and then flat on the posterior side as opposed to increased concavity on the anterior side. So lateral, most of the time we're going to do each individual finger individually on lateral. Remember, whenever we get into hands, we've got both fan lateral and extension lateral, and the purpose is really, as far as Merrill's goes, the purpose and the difference between those two is that you do the extension lateral for foreign bodies and you do the fan lateral for individual fingers. So it stands to reason that if we're looking for fractures in the fingers, then we're going to do each one individually. You could do more than one on a single image, but you've still got to fan them out and get them off of each other so that you don't have, not only soft tissue, but certainly the bony overlap. So you may need some positioning aids to get the patient into proper positioning. And again, the lateral depends on the digit. We'll have lateral side down for digits number 2 and 3, medial side down for 4 and 5. Remember, that's from anatomical position, which means with the palms facing forward, the pinky finger is on the medial side. So the 5th digit's on the medial side. So the 4th and 5th we're going to do with medial side down. And just as we looked at previously, convexity, concavity is what we're going to be looking for. Convexity on the posterior side, concavity on the anterior side. Very little soft tissue on the posterior side and quite a bit of soft tissue on the anterior side. I include this excuse me, because the ring finger, which is what they're trying to demonstrate here, is sometimes difficult to get extended by itself, all by itself. And if the patient truly has a broken finger, that's probably not a good thing to do to the patient, to take and force their finger out. Keep in mind that whenever you extend your pinky finger, your ring finger tends to want to go with it, and it sometimes is easier on the patient to just extend the pinky finger as far as possible and let it drag the ring finger out with it. Again, if the patient's got a fracture of maybe the proximal or even the middle phalange, and you take a tongue depressor and push on it like that, it's going to be very painful for the patient. So probably not a good idea. So again, a lateral, we've got all 3 phalanges. We've got some bony overlap on the proximal end that, of course, you cannot get away from. But your central ray, again, is going to be to the proximal interphalangeal joint. Keep it parallel to the image receptor so that the joint spaces are perpendicular to the image receptor. Central ray goes through the joint spaces. And we're going to look at that convexity on the posterior side, concavity on the anterior side, and the difference in soft tissue between anterior and posterior. So our thumb, remember, is the only digit that we routinely shoot AP. It's the only finger that we routinely shoot AP. Everything really still applies to the thumb as what applies to everything else. And that is, for the AP, we're going to look at the difference between, actually we're going to look at symmetry of the convexity on both sides. We want that hourglass shape. For rotation, we're going to evaluate convexity, concavity, the difference in soft tissue. And in a lot of cases, since we're shooting it AP, the rotation is going to appear a little bit different than what it did for the rest of the fingers. It's the only digit that we routinely perform AP, and it's also the only digit that we routinely include the entire metacarpal. And that is because we've got an opposable thumb, and some of our fractures of that individual digit are very proximal. Ski pole injury, also referred to as a Bennett's fracture, is a fracture of the proximal end of the first metacarpal. It's the only digit that since we're including the entire metacarpal, we're going to center at the metacarpal phalangeal joint. We have to be very careful of soft tissue overlap on the hand. You can put the posterior portion of the thumb in contact with the image receptor in a lot of different ways. I've seen people use the wall bucky actually and have the patient stand up with the posterior portion of their hand on the wall bucky itself. Let me turn the camera on. So I'm at home. So I've seen people put the wall bucky, their thumb directly on the wall bucky and shoot like that. And that's fine. Just make sure that you collimate well, put an apron on the patient, have them turn their head away from the anatomy so that you protect the eyes, do all the radiation protection things. I've also seen patients or people rotate their hand around like that for an AP, and that's fine as well. I'd say with this orientation, you're more likely to get soft tissue overlap over the proximal end of the metacarpal. So, just be aware of that. If you're going to rotate the hand around like that, just make sure that you extend the hand out, or possibly just have the hand rotated in that orientation. So, a lot of different ways to get there. Just make sure that you minimize that soft tissue and the bony overlap whenever you use any of those projections or positionings. The lateral, whenever you're putting the patient into a lateral projection, what you're going to do is just go back to the camera, is bend the fingers up, rotate the fingers up, it automatically rotates the thumb into a lateral. So lateral places the hand in a little bit of a oblique position, and with the hand prone, the thumb is in an oblique position. So again, I'm going to go to this. So with the hand flat like that, the thumb is naturally rotated into an oblique position. Full disclosure here, there's some kind of tricky questions on the test that you need to pay attention to. You are second year students, halfway through, you're next to the last semester. You really should know the difference between projection and position. So make sure that you understand the question before you jump on certain answers. Projection is path of the x-ray beam, as opposed to the hand position is just that, position. Prone versus supine versus lateral versus PA projection versus AP projection. So I wrote those, and every year I think about editing some of those out, but I want to keep you on your toes. So make sure that you pay attention to the test questions. And don't answer for a projection whenever it's calling for a position, or don't answer with a position whenever it's calling for a projection. So oblique places a hand in a prone position. All right, so relatively good AP. It's really difficult to get a thumb with no rotation whatsoever. That's pretty close to as good as you're going to get. You've got all the way down to the carpal metacarpal joint space. You've got very little soft tissue overlap on the proximal most end. You've got open joint spaces. You got a good lateral. That's good thumb. So rotate the fingers up. Bend the fingers a little bit. That puts the thumb in a lateral position. And so looks like that.